Good evening and welcome to the Epilepsy Foundation of Minnesota's Wellness Wednesday webinar, Making the Epilepsy Diagnosis, the overall process and testing that plays a role. I'm Debbie Leone. I am the Client Services Manager for EFMN. We are thrilled to be partnering tonight with Dr. Elaine Wirrell of Mayo Clinic to bring you this webinar. And Mayo Clinic is also sponsoring the webinar, so we are very grateful for their support. While EFMN is hosting this webinar, all content and discussion points are led and delivered by our guest speaker. The information shared is to inform you about various aspects of the epilepsy diagnosis process. However, specific concerns about your or a loved one's diagnosis should always be discussed directly with your medical provider. I want to talk just shortly or briefly about EFMN's programs and services that we have to offer. This is a big week for us because we're right in the middle of camp week. We have 90 campers out at our Camp Oz, which is our traditional week-long camping experience, and they are enjoying themselves tremendously. In July, we will also be having our family camp and day camp experiences, which is for those who are younger or who may have additional needs socially, physically, or emotionally. We have virtual connect groups that most of them meet monthly. We have a total of 8 different groups for different audiences. 6 of them meet monthly, 2 of them meet quarterly, and you can go to our website and see all the different groups that we offer those connect groups for. But it's just a place where people who are impacted by epilepsy in some way can share experiences and offer each other support in a safe and supportive environment. Education services includes not only these webinars, but also seizure smart trainings in schools, workplaces, and other organizations. Client services provides epilepsy-related information, resources, and referrals that are done through free one-on-one customized support. So people can call us or email us with any questions related to epilepsy in any way, and we will do everything we can to provide them with the information or the resources that they need. Our Shining Star program is for kids from birth to age 17, and it provides special events throughout the year just to connect youth with epilepsy to each other, and that happens for kids across the state of Minnesota. Our social events offer fun activities throughout the year, again throughout the state. Our advocacy efforts aim to shape policy at the state and local levels, and our goal is to try to make Minnesota a better place for those who are living with epilepsy. And finally, the clothing and the household items that we collect through our donated goods program are one of the things that helps us to fund all of these great programs and services that we're able to offer. These are just some of the upcoming events we have over the coming month or so. You can see the different virtual connect groups, our camp programs, a social event. I do want to point out that our United in Epilepsy regional walks are coming up, and these are just a way for us to raise awareness about seizures and to offer support and just to cheer on the folks in our epilepsy community. So we hope that you'll join us for at least one of those walks or maybe one of our other events coming up. And you can find more information about all of these at our website at epilepsyfoundationmn.org/events. A few housekeeping items before we dive in. The webinar will last for 1 hour and 15 minutes. And we do ask that if you have any open screens on your devices, especially anything having to do with music streaming or anything like that takes up a lot of bandwidth, please close those out and you'll have a better webinar experience that way. We do offer a certificate of attendance that will be mailed to you in an email within 3 business days after the end of this webinar, and we will also be sending out the PowerPoint slides, so you'll be able to refer back to them. The webinar is being recorded as well, and a link to view that recording will be posted on our website within the next few weeks. So again, go to the EFMN website to look for that. You'll also receive an email from me when that has been posted. You will notice that we have closed captioning activated. If you don't want to see those captions, you can click on the CC icon, which should be at the bottom of your screen, and there you can choose to hide those subtitles. We will be offering you a chance to ask questions. That can be done by clicking on the Q&A icon. You can see it circled here on the screen at the bottom, usually at the bottom of the screen. That will bring up a box where you'll be able to type in your question and hit send. We are going to save these questions until the end of the webinar, until after Dr. Wirrell has done her presentation. But if you think of questions as she is speaking, please get them in there so that you're sure to get your question answered. We will answer as many of those as we have time to do at the end. You can also use that Q&A box if you have any kind of technical questions or problems throughout the webinar. My colleague, Nikki Baker, is here behind the scenes, and she will do what she can to help if there anything like that comes up. And to avoid confusion, you should also know that the chat feature has been disabled. And I know we always get a question, can other people see me? No, your cameras and microphones have all been muted and turned off. So let's talk about our objectives tonight. Our objectives are define what epilepsy is and identify other conditions that may mimic seizures. Recognize that epilepsy is not just a single disorder, but encompasses a variety of seizure types and syndromes. Learn what diagnostic exams and tests are commonly performed, how they're done, and what information they provide. Understand how determining seizure type can help guide decisions regarding testing and treatment. So now it's my pleasure to introduce you to our speaker for this evening. Elaine C. Wirrell, MD, is the Director of Pediatric Epilepsy at Mayo Clinic. She specializes in early onset epilepsies and epileptic encephalopathies, including West syndrome, Dravet syndrome, myoclonic atonic epilepsy of Deuce, Lennox-Gastaut syndrome, and CSWS. Her clinical focus also includes early medically intractable pediatric epilepsy, ketogenic diet therapy, and surgical therapy for epilepsy. We are very honored to have her here with us tonight, and I am now going to turn control of the slides over to her, and I will, if I can get there, okay. Okay, I'm now going to turn things over to Dr. Wirrell.
Great. Thank you so much for the kind introduction, and thanks for inviting me to be here today. It's really an honor to be here, and thank you for the audience for joining. I know it's a lovely evening out, and I appreciate you spending your time with us. So as advertised, I'm going to talk a little bit about making the diagnosis in epilepsy, how we go about that process, and really why we do that process, and really to try and define the specific type of epilepsy. So here are our objectives. So first of all, we're just going to review very quickly about what do we mean by the term epilepsy, how has that been defined. We'll talk a little bit about other things that can mimic seizures, and that's because sometimes it can be a bit challenging to make an accurate diagnosis of seizures all the time. We'll ask the question, is epilepsy just one disorder? What types of tests are commonly done? And really, why do we do that? How does determining the type of epilepsy you have or your loved one have actually help? So the International League Against Epilepsy, this is the International Association of Healthcare Providers that are interested in researching and managing epilepsy, has defined epilepsy as a disorder of the brain that is characterized by an enduring predisposition to generate epileptic seizures. And also, I think very importantly, by the neurobiological, the cognitive, the psychological, and the social consequences of this disorder. And so what this definition says is it's not just all about the seizures, but there are many other symptoms of epilepsy, what we call the non-seizure symptoms. And those are things like learning issues, psychology issues, anxiety, depression, the social consequences of having a seizure disorder. And so really, if we're going to manage epilepsy, we need to be paying attention not to just the seizures, but also to these other aspects. And if they sort of come down, the rubber meets the road, and what they say is epilepsy can be defined as any of the following. So somebody who has had at least 2 unprovoked seizures, and unprovoked seizures mean that they haven't been brought on solely by high fever or low blood sugar or things like that. So 2 unprovoked seizures that occur at least 24 hours apart, or in somebody who's had 1 unprovoked seizure who has a high probability of going on to further seizures based on the underlying cause. So we know that if you have certain changes in the brain or certain genetic conditions, you are very, very likely to go on to have more seizures. And so in those individuals, we can diagnose epilepsy after just a single seizure, or if you have an epilepsy syndrome. And we'll talk about what we mean by that shortly. So how common is a first seizure? And many people are kind of surprised to hear this, but it's common. About 1 in 10 individuals at some point in their lifetime will have a seizure. Now, some of these will be provoked seizures like febrile seizures, but 1 in 10 people will have a seizure at some point. And then how common is epilepsy? And it's also very common. 1 in 26 individuals will be diagnosed with epilepsy at some point in their life. So this is actually a very common condition. It's often relatively untalked about, but it's a relatively common condition. So the first thing when I'm seeing somebody who is referred in with, I think they've had a seizure, the first thing that's in my mind is this truly a seizure or is this something else? Because there's many things that can mimic epilepsy. And some of the common ones are listed here. So we call them certain movement disorders, so little habitual movements, sometimes little tic movements, sleep disorders like sleepwalking or sleep talking sometimes can be misdiagnosed as epilepsy. Even sometimes normal sleep phenomena. So a lot of people will do chewing in their sleep or will have what we call rapid eye movements during a stage in sleep. And so those can be associated with normal sleep, but can be miscalled as epilepsy. Fainting or heart problems, because people can pass out, it can be miscalled as epilepsy. Different migraine phenomena, what we call functional spells. Other people call these PNES, but we call them functional spells, common misdiagnosed as epilepsy, panic disorders, and rage attacks. So you can see here a very large number of different conditions that can mimic epilepsy. And so how good are we at making the diagnosis? And this is perhaps a little concerning, I think, if you look. So if you look at adults with epilepsy, this is looking at misdiagnosis rates. So if you see a non-specialist, a non-neurologist, about 19% of the time, they think it's epilepsy when it's not. The neurologists do a bit better job. So they only get it wrong about 5% of the time. And when they looked at in adults, what are the most commonly misdiagnoses? Those are fainting spells and then functional spells. In children, it's even worse. So anywhere between 1/4 and 1/3 of children who are referred with what is felt to be a first seizure probably never actually had a seizure. They had something else. And there was one study that found that about 39% of kids who were admitted for seizure monitoring actually didn't have epilepsy. So you can see here that these rates are pretty high. And why are they high? I think they're high because there's lots of things that can mimic epilepsy. And it really does take time to get the right story and to make sure you get an accurate story, because the story of actually what has happened from both the person who had the event as well as the person who witnessed the event is the most important thing that will give you the correct diagnosis. The other thing that sometimes can be a problem is that people misinterpret the EEG. So the EEG is full of squiggly lines, as many of you know. And sometimes people can miscall those squiggly lines as epileptic or epileptogenic. And then there's also a lot of pressure for the answer, right? Because seizures are pretty scary. And so when people come to you, you really want to be able to say, yes, that was, or no, that wasn't. And in truth, sometimes we have to say that occasionally we don't know for sure. And sometimes it just takes a little bit more time to get an accurate answer. Jumped ahead. There we are. So when we look at making the diagnosis, as I had mentioned, the most important part of making a correct diagnosis is getting a careful description. from both the person who actually suffered the suspected seizure, as well as whoever witnessed that seizure. And so, seizures that happen at school, seizures that happen away from the family can be more challenging. And so very, very helpful if that person who witnessed can provide their phone number or can provide a brief description of what they saw. Now, one of the things that many people assume is that epilepsy is one disease. It is one problem, and it really isn't. Epilepsy is a large group of different disorders. All of those disorders have in common the fact that there are recurrent unprovoked seizures, but recurrent unprovoked seizures can happen for many, many different reasons. And many of those different epilepsies behave quite differently. So some of them will be outgrown, some of them won't. Some of them will be easily controlled with medicines. Some of them won't. Some of them can be respond very well to epilepsy surgery. Others can't. And so it's really important to look at the different types and try and define what type of epilepsy do you have. So why is it helpful to determine the specific epilepsy type? Well, there's lots of tests that we can do. I'm sure that many of you are aware of all of those tests that we can do. You've been through a lot of them, but we don't want to sort of throw the book at you and do every test that we can think of. We want to select the tests that are most likely to give the cause so that you're not going through a ton of tests, and also it can be very costly to do all of those tests. It also helps us choose what are the best treatments and avoid treatments that can worsen seizures. And so some of the anti-seizure medicines actually can worsen certain types of epilepsy, so we want to avoid those. It's also important because if we identify the epilepsy type, that helps us also identify possible non-seizure symptoms of epilepsy, what we call the comorbidities. So the learning issues, the anxiety, the depression, the ADHD, things like that. And it also provides more accurate information to you on how your epilepsy will likely behave. Is it going to be an epilepsy that is easily controlled or not? Is it going to be an epilepsy, if you're a child, that will be outgrown or not? So moving on to what type of epilepsy is this? So the International League Against Epilepsy, again, this is the group of healthcare providers, international healthcare providers that are joined together to really study epilepsy and to come up with the best treatments for epilepsy, have classified the epilepsies at various levels. So first of all, they look at what type of seizures are you presenting with, then what type of epilepsy is this, and then is there an epilepsy syndrome, and then we see is there a certain cause, and then what are the comorbidities or the non-seizure symptoms. So let's take those each one at a time. So first of all, what type of seizure is this? And here we have really two big groups. There's the generalized onset seizures, and generalized onset seizures, as you can see here, involve both sides of the brain from the onset. And they come in different flavors. And so probably the most common generalized onset seizure that people recognize are what we call a generalized tonic-clonic seizure, where there's really no warning. Suddenly the person stiffens, sometimes they can cry out, they bring their arms up, and then they have rhythmic shaking. You can also have generalized tonic seizures where you just have that generalized stiffening, but you don't have that rhythmic shaking. You can have generalized atonic seizures where suddenly you abruptly fall, you lose all tone and often injure yourself. And then there's the absence seizures where typically suddenly out of the blue, you stop, you stare, you may chew, that may go on for 10 or 20 seconds, and then it's over and you're back again. So those are what we call the different types of generalized seizures. Then they're what we call focal onset seizures. And focal onset seizures start on one spot or one side of the brain. They can then spread to other spots on that side of the brain, or can spread to the other side of the brain as well. And there's different types of focal onset seizures. So one type is what we call focal aware, where the seizure starts focally on one side of the brain, but that person is completely aware during the seizure. They can tell you what's happening. They might say, I'm starting to feel some tingling in my thumb, or they might say, my thumb is starting to twitch, but they are completely aware and can carry on a conversation during that. Oftentimes, however, particularly if the seizure spreads to the other side of the brain, we see some impairment in awareness. And it doesn't mean that their consciousness is necessarily lost. They are just confused and they are less able to respond than they normally are. So that's what we call a focal impaired awareness seizure. At the second level, we ask, what type of epilepsy is this? And here is where we put all of those seizure types together. And we say, right, if they're all generalized onset seizures, so you have somebody with generalized tonic-clonic seizures without any warning, and you have somebody with absence seizures, all of those are a generalized seizure type. So this is a generalized epilepsy. If you have somebody who has focal onset seizures, so they may stare, they may lose awareness, they may have sort of a funny rising sensation, or they may have that type of warning and then go into a tonic-clonic seizure. Those are all focal onset seizures, so that's a focal epilepsy. But we also see, and this is really important in young children, people who have both generalized onset seizures and focal onset seizures. And so we call this a combined generalized and focal epilepsy. And this is more common in epilepsy starting in early life. So the next level is what we call epilepsy syndrome. And not everybody has an epilepsy syndrome, but if you can make a diagnosis of an epilepsy syndrome, it's a much, much more specific diagnosis. And what it does is it looks at what types of seizures do you have, what are the findings on the EEG, what is the age at onset of this, do we know what the specific cause is? And if we can identify syndromes, oftentimes that helps us to say, this is a better treatment for this specific syndrome, or this is a medicine we don't want to use because it's going to make things worse. It also gives much clearer information about how likely the seizures are going to be controlled. So is this going to be an epilepsy controlled with medicine or one where we really, really struggle to get control? And also the likelihood of being outgrown. And it gives us much more information on the likelihood of being associated with other comorbidities. So we have certain syndromes where we say these are benign syndromes or relatively benign syndromes, well-behaved syndromes. We know they are likely to be well controlled. Oftentimes, if they happen in children, they're likely to be outgrown, and they really don't cause any developmental problems in children. And then we have other syndromes, things like Lennox-Gastaut syndrome or West syndrome or Dravet syndrome, where the seizure control is often much, much more challenging. They are less likely to be outgrown, and they are highly associated with other comorbidities like learning problems. And we see syndromes are most common in children who have epilepsy early in life. So children who have onset of epilepsy before age 3, about half of those children can be defined as having a specific syndrome. And this is much less common if we see epilepsy starting in adulthood. Usually we cannot define the syndrome in that case. So just as an example, this is Adam, you can see here. He's out camping with his family, and about 6:30 in the morning, his mom wakes up. She hears Adam making this choking sound. She notes twitching of his left face, and that goes on to a full body seizure that lasts for about 3 minutes. When you see Adam, he looks like a normal kid. He's doing really well at school, and his exam is normal. And his EEG shows these discharges here that we call in the centrotemporal region. And they're predominantly on the right. And that makes sense because the right brain controls the left side of the body. And so putting this all together, we say he has a focal onset seizure. That seizure evolved to bilateral convulsive, right? Because he had the generalized tonic-clonic activity, but only after he started having the twitching of his left face. And if we put this all together with the EEG finding and the fact that Adam otherwise looks very normal, we can say Adam most likely has a syndrome called self-limited epilepsy with central temporal spikes. We call it SELEX. And we can say he is going to outgrow this. This is something he always will outgrow by the time he's usually in mid-adolescence. We can be very reassuring and say it's not due to a brain tumor. It's not due to anything else that's bad. If medicine is needed, and probably we wouldn't treat him after the first seizure, but if medicine is needed, the seizures are very likely to be easily controlled. And his risk of learning or behavior problems are very, very low. So this is one we can be very reassuring. Looking at Beth, this is an 18-year-old Beth, and she presents with a 2-year history of seizures. And what she describes is she feels sick to her stomach. She kind of feels this sensation that something is coming up from her stomach into her chest. She then slowly loses awareness and actually becomes unresponsive. And her loved ones describe that she chews and she stares during this time. And the seizure generally lasts a couple of minutes. And afterwards, she's quite tired and confused and usually wants to sleep. And more recently, Beth has also been experiencing greater difficulties in school. She's having more memory problems. And so listening to this story, this sounds like a focal seizure. The description sounds like a seizure coming from what's called the temporal lobe. And in fact, when we look at her MRI, what we see is that in this temporal lobe on the right, we see that this structure here is pretty flattened compared to this other structure here. And this would be in keeping with what we call hippocampal sclerosis or mesial temporal sclerosis, which is an area of scarring in the brain that often is associated with this type of seizure. And what does this mean for Beth? So she has this mesial temporal sclerosis and mesial temporal lobe epilepsy. What this means is that for Beth, we can say that there is a very high likelihood that seizure medicine is not going to work to stop her seizures. So we know from other patients with this that anti-seizure medicine doesn't work very well in this type of epilepsy. However, we know there is a very high likelihood for Beth that if we do epilepsy surgery, that will be successful, and that Beth will likely be able to remain seizure-free and come off medication. And we also understand why Beth is having a lot of memory problems, because a lot of people have memory problems with this type of epilepsy, and many of them also have mood disorders like depression. So the next thing that we want to think about, once we kind of think about what is the type of epilepsy, what is there a syndrome or not, is there an underlying cause of the epilepsy? And here we've become quite a bit smarter over the last 20 years or so. We have a much better understanding of the genetics, doing the different DNA tests. We have a much better ability to look carefully at the brain, doing different imaging tests. And so we are much better at finding the underlying cause than we were even 20 years ago. Now, the most common underlying cause is what we call a structural abnormality. And so this is a change in the brain structure. And usually you can see this on an MRI study. Sometimes this is a result of abnormal brain development. And many of those cases, we don't understand why that brain developed abnormally in the womb. So most of these babies are born to, people who have had very normal pregnancies, but then are found to have these developmental brain abnormalities. And then some of them can be due to brain injury, things like infection or stroke or trauma. And so here's just some examples. Here's a child with a very abnormal hemisphere, a very thickened abnormal hemisphere. And this child has what's called a hemimegalencephaly. And this is a developmental change that occurred while the child was still in the womb. And then here's a person who unfortunately has had a gunshot injury to the head. And so he's had a significant injury to his frontal lobe. And so you can see here, the MRI is pretty good at showing these structural abnormalities. Another really important cause of epilepsy are genetic causes. And here is, I think, where we've probably made the most strides over the last few years. And what we know are there are many, many genes that can contribute or can cause epilepsy, probably over 900 genes now that can cause epilepsy. And we say that epilepsy is most likely to have a genetic cause if there is a known presumed gene variant that is associated with epilepsy. And so this is something that we would find on genetic testing. Importantly, just because we say it's genetic, it does not mean it's going to be inherited. And that's really important for people to understand. We always want to make sure that families see genetic counselors, but it doesn't necessarily mean that this is something that's going to recur in subsequent pregnancies. So we have some children, actually many children, who have early onset epilepsy, more severe epilepsies, where there's a genetic change, but that genetic change has occurred as a new change in the child and is not present in either parent. So that can be one situation. And also importantly, just because you have a genetic cause, it doesn't exclude that there's also an environmental component. So sometimes inheriting a gene will increase your risk of epilepsy, but not to 100%. But then, for example, if you have a traumatic brain injury, then that's sort of a second hit. And that combination of the traumatic brain injury and the gene change can give rise to epilepsy. So there's different types of genetic epilepsies. There's sort of two big groups. One of the group that we call polygenic. Poly just means many, so many genes. And here the person has inherited changes in many different genes, not just one gene, many different genes, oftentimes in combination with different environmental factors that can potentially make them more prone to have epilepsy. And in this situation, because there is one person who has all of these genes, we assume that family members at least have some of these genes as well. And so here family members have a slightly higher risk of epilepsy. And then there's another group of disorders, and this is more commonly in early onset epilepsies, where the person has just one single gene that is responsible for the epilepsy. And so examples here would be like a tuberous sclerosis gene or a CDKL5 gene. And sometimes these genes can be inherited from the parent, but even more commonly, they occur as a new change in the child. And it's really important to know if this is inherited from the parent or occurs as a new change, because if it's inherited from the parent, there is a much, much higher risk if the family decides to have future children. If it's a new change in that child, the risk is very, very low. So what types of epilepsy can be genetic? So probably one of the biggest groups is what we call the idiopathic generalized epilepsies. And that includes situations or conditions such as childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy. These are very, very common. They account for probably about 1 in 4 people with epilepsy. And we know that people who have these epilepsies do have higher rates in other first-degree relatives. So this would be like your parents or your siblings or your children. And here about an 8% risk of epilepsy in first-degree relatives. Again, because these are inherited, presumably due to multiple genes that you have been passed down or that you have passed down to your relatives. And so your other relatives are also going to have a good collection of those genes. And here, while we say this is genetic, if you actually look for a specific gene, you generally don't find one, just because this is so many genes involved and each gene is giving a little bit of a risk. If we have severe epilepsy starting in early life, about half of those children are going to be found to have a genetic cause. And the earlier the onset of epilepsy, the higher the likelihood of that having a genetic cause. So that group in particular, we really want to look carefully for an underlying genetic cause. And then we also see some families where they can have increased focal epilepsies in the families. And here there's a number of different genes that can be associated with developmental brain changes in certain areas, like tuberous sclerosis or something like DEB-DEC5. And so those genes can be found in specific families and can increase the risk of other family members being affected. So identifying the gene cause is really, really helpful also in determining what is the best treatment and what is the best or what is the likely outcome. And so here's an 8-month-old girl, and she's had 3 brief focal seizures. Her mom's pregnancy was normal. She was delivered at the right time. She has enjoyed normal development. Our initial evaluations, including her physical examination and her neurologic examination, the EEG and the MRI were all normal. But the parents were really, really worried because her cousin actually had Lennox-Gastaut syndrome. And so they were very, very worried that this little one was going to develop terrible epilepsy. And so we did a gene panel on her. And her gene panel came back showing this gene called a PRRT2 gene. And we know actually that this particular gene is generally associated with self-limited epilepsy in infancy. Infants will have some focal seizures, usually not very frequent. Many of them will respond very well to medications like carbamazepine or oxcarbazepine. And almost all of these children will outgrow their epilepsy, usually within a couple of years, and there will be no impact on the child's development. So just being able to provide this information to the family, finding this specific gene variant was really, really helpful. On the other hand, this is a 5-month-old girl, and this young one has had a much more difficult course. So she has had recurrent seizures since a month of age. She has had several admissions to the ICU for seizures that would cluster and wouldn't stop. She has been tried on 4 medicines in her short life so far, and her MRI was also normal. But clearly there was something going on, right? She had quite severe epilepsy. So we also did an epilepsy gene panel on her, and she was found to have a variant in a different gene, something called SCN2A. And this is an important cause of a rare but often severe epilepsy in infants. And the one thing that we got from this is children with this particular disorder respond very, very well to high doses of phenytoin or dilantin. And so this information told us why she was having severe epilepsy, but it also told us how to treat her. And so on the high dose phenytoin, she has actually done much, much better with a marked reduction in her seizures. And then we have what we call metabolic causes. And so what's a metabolic cause? Well, we all take in food and we have lots of proteins in our body that help to break down our food and turn them into nutrition so our bodies can use them for nutrition. And when you have a metabolic cause, one of these proteins is not working as it should. And so you can either have a backup, so you can have an excess amount of this intermediate substrate that can then prevent the cell from functioning normally, or you can prevent the generation of normal energy that cells need to function normally. And so these are important to recognize because they can have really specific implications, again, for what is the best treatment. So this is a 3-year-old girl who had both staring spells and tonic-clonic seizures, and she had been tried on 5 seizure medicines. Over the preceding year, her parents really had noted her development was starting to plateau. She had been doing pretty well for the first year, but by the time we met her, she was clearly showing some degree of developmental delay. And so we did testing for her, and that showed that she had a disorder that impaired getting sugar from her blood to the brain. And we know that the brain really lives on sugar. It needs sugar for energy. And so her brain was kind of starving despite the fact that she was not. And so we had to figure out a different way to get energy to her brain. And so we used a special diet called the ketogenic diet. And with that, we've been able to nourish her brain very well, and she became seizure-free, and her development is really progressing. So again, identifying that cause was really critical in knowing how best to treat her. And then there's other causes, so infectious causes. Infectious causes are the most common worldwide, but most of those patients are in developing countries. And so common infectious causes there would be things like malaria, HIV, things like that. In developed countries, it is less common. Now, this is an MRI of a baby whose mother had a congenital infection, cytomegalovirus, during the pregnancy. And you can see here that this really has caused significant malformation of the brain and some abnormal calcium here. And then immune-mediated causes. These are more recently recognized as well and important to recognize as far as identifying what's the best treatment. And here, the body produces what's called an antibody or a protein that attacks the brain. So it's quite similar if you think of anybody you know with like rheumatoid arthritis. If you have rheumatoid arthritis, whatever reason, your body starts producing proteins that attack your joints, and then your joints swell up and you have bad arthritis. This is a similar thing, except those antibodies are now attacking the brain. And so the person is presenting with seizures, often cognitive concerns, and other symptoms, sometimes movement disorders. And then looking at unknown causes, people often get frustrated when we've done all of our tests and we say, you know what, we've done all of our tests and they're normal. But that's actually a pretty common thing. So about 40% of people with epilepsy, we don't find a known cause, despite doing MRI and genetic studies and lots of blood work. And that can be frustrating. However, I do tell my parents that it is really helpful, actually, if you have a child who is what we call neurologically normal, so that means their exam is normal, their development is normal, and they have focal epilepsy and we can't find a cause, the outcome is very, very favorable. So although it's frustrating we can't find a cause, it's actually very, very good news to you and your child. Because what this means is that 2/3 of these children will eventually outgrow their epilepsy. pretty high. And only somewhere between 7 and 12% will develop what we call drug-resistant epilepsy, or epilepsy that is not responding to 2 or more medications. So again, sometimes if we do an extensive look and we don't find a cause, that can still be very, very good news. So moving on to the comorbidities. So the comorbidities are really important to pay attention to. These are the non-seizure symptoms of epilepsy, and they can have a really tremendous impact on well-being and quality of life, both for the child as well as the rest of the family. So I think that if you're treating epilepsy, we have to treat other symptoms other than just the seizures. So this includes things like academic underachievement, unemployment or underemployment, intellectual disability, mood disorders, things like anxiety and depression, ADHD and behavior problems, loss of independence in driving, sleep problems, very common in people with epilepsy. Autism is pretty common in young children with epilepsy, bone problems like osteoporosis with fractures, and then the risk of seizure-related injury and sudden unexpected death in epilepsy. So these are all things that we need to be addressing. And comorbidities are really critical to identify early on. And I think that in people coming in with epilepsy, when we're making a new diagnosis of epilepsy, we need to be asking about them. And don't be shy to bring these up to your healthcare provider. If you have comorbidities and you really feel these need to be addressed, they do need to be addressed. So it's really important to identify those, because many of these are treatable, right? And if we don't know that depression is there, we're not going to treat it. If we know it's there, we have some very good treatments for it, as for migraine, as for ADHD. And we know that these have a very significant impact on quality of life if we don't adequately manage those. And it may not be that your neurologist is able to manage every single aspect, but they should have a team of people they work with who could help with that. So let's talk about some of the commonly used investigations for persons with epilepsy. So many of you or your loved one will have already been through what we call an EEG, or an electroencephalogram. And here we have these very small electrodes, these little discs, as you can see here. They're attached to the scalp, and then they are connected by wires to an electrical box. And what this does is it records electrical activity from the brain, and it can show patterns of normal or abnormal brain activity. Many kids don't like to have these put on the head, but they're relatively painless to get applied. And so what can the EEG show? Here is, you can see squiggly lines, but if you look here, you can see that where I've made these red circles, these are what we call sharp waves. So you can see that these are abnormal structures, really in what we call, this is in the right temporal region. And so this is what we call an epileptiform discharge, or an epileptic spike. And in somebody who had the right history, we would say, boy, that would be in keeping with seizures that are coming from the temporal lobe. Over here, on the other side, what we see is some abnormal activity, what we call slow activity. And this is in also the frontal temporal region on the right. This is a different patient. And when we see a pattern like this, that makes us think, is there some type of a structural abnormality, like a tumor or something like that, that is involving this area. So the EEG can show us really important information that can help us manage the patient. So how useful is the EEG? And unfortunately, the EEG is not a perfect test. So in somebody who comes in with a first seizure, somebody with a new onset seizure, the EEG will show abnormal discharge in about half of people, meaning that it doesn't show abnormal discharge in the other half, right? So just having a normal EEG does not exclude a diagnosis of epilepsy. The EEG is more likely to be abnormal if it's done in the first 24 hours following the seizure. And it's also more likely to be abnormal if the person is able to sleep during the recording, because sometimes sleep will bring on certain seizure discharges. There are some caveats to the EEG. So as I already mentioned, the EEG is often normal after the first seizure. So just because you have a normal EEG, that doesn't mean it's not a seizure. Even if it's abnormal, it doesn't mean that you have epilepsy. So if we sort of went and rounded up 100 grade 6 students and brought them in for EEGs, about 3% of them will show evidence of seizure discharge, even though they've never ever had a seizure. So again, you really need to combine the information you're getting from the EEG with a really careful clinical history to get the diagnosis right. So how can the EEG help? Well, it does provide supportive evidence that this person likely has seizures if it's abnormal. It doesn't tell you it's not if it's normal, but it provides supportive evidence if you already say, boy, that really sounds suspicious for seizures. Sometimes it can detect subtle seizures. So sometimes people who come in with their first seizure, it's more likely to be an obvious one where they shake all over and fall over. And some of these people can have short little staring spells, absence seizures, or focal seizures that have not been recognized. And so sometimes we can see those on the EEG. It can also be helpful in determining if the epilepsy is focal or generalized. And if it's focal, we tend to see the discharges coming from just one spot in the brain. If it's generalized, they're really coming from all different aspects of the brain. And that can impact our decision on whether we need to go and do an MRI or not, or specific treatments that we use. Sometimes the EEG is helpful in defining an epilepsy syndrome, so that very specific diagnosis. And then sometimes the EEG can also record spells that aren't epileptic. So if somebody has an EEG and then they have a heart arrhythmia and they pass out, that's very helpful, gives us good information. It says it's not epileptic, but it also gives us good information saying, boy, you need to see a cardiologist. Moving on to imaging of the brain. So it's recommended that essentially all persons with epilepsy undergo an MRI test. And the exceptions are those who have really well-defined generalized epilepsies that respond well to medications, things like childhood absence epilepsy or juvenile myoclonic epilepsy. If the EEG and the story is very clear and you respond well to medicine, you don't need an MRI. And also children who have these clearly defined self-limited focal epilepsy syndromes, like Adam that I showed you, who had been out camping with his family. He does not necessarily need an MRI, but pretty much everybody else should. And what is an MRI? The MRI is a very strong magnet, and it uses the strong magnet to take a picture of the brain. And it's helpful because it doesn't actually expose the brain to radiation like a CT scan or other X-rays can. So here's a picture. So the person lies on this bed. They put their head in this device here, and then the whole bed slides into this tube. For some patients, if they're very anxious or young children, you may need sedation. And the MRI takes about an hour or so. It can be kind of loud, a bit scary. Sounds like somebody's building a house next to you, but it is otherwise a very safe procedure. Now, how does the MRI findings help? So about 10% of adults with new onset seizures will actually have a cause found on their MRI. And if you have an abnormal MRI, that actually tells us that you are going to have a higher risk of having a seizure recurrence. But sometimes the MRI tells us things that are really incidental, sort of what I call freckles on the brain, right? You have them, but it doesn't really make any difference. And so here's somebody who, if you look at them, you can see their eyeballs here. They have this cyst on the temporal lobe, but this is what we call a benign cyst. It's often found in people who don't have epilepsy, and it's unlikely to be related to the epilepsy. So remember, the MRI sometimes will show you these benign variants that have really no relation to the epilepsy. Moving on to genetic studies, it is really important to talk about the potential implications of genetic testing before that testing is done. And genetic counselors can be really helpful here. So there are some medical implications. Some of the genes that are looked for in some of the tests can have implications for symptoms other than epilepsy. So for example, they can pick up a gene for Huntington's, or they can pick up a gene for Alzheimer's or for breast cancer. And so it's really important that people recognize that depending on the test that's done, they may get more information than they bargained for. And you can often talk to the geneticist, and you can decide if you're just going to get information on the genes associated with the epilepsy, or you can request that you get all of that information. And remember that because it is genetic testing, those implications often extend to relatives too. There is reproductive implications, so the risk of passing on an abnormal variant associated with disease to future children. And many families, if they feel they are carrying that, want to know what the risk is. There's psychological implications if you're found to have a specific gene or for parents where you didn't know you had that gene and now your child is affected. That can be very, very problematic for many families. And so really kind of thinking how they will be counseled and we'll deal with that. And then there's insurance and financial implications just for medical insurance, for example. So important to discuss all of those things before you do the testing. And then how is testing done? Most of the testing that we do is on blood samples, but you can also do saliva samples or cheek swab samples. So pretty easy to do. And remember, there's different genetic tests, and there's not a single test that can diagnose all genetic epilepsies. There are some tests where they focus on specific individual genes. Those are less commonly done. There's other tests that focus on groups of genes, what we call epilepsy panels. Those are more commonly done. And then sometimes they look just at the chromosomes. So the epilepsy gene panel is probably the one that we use the most. And this looks at now over 400 genes that are associated with epilepsy. And increasingly, we see this number going up. So a few years ago, it was a couple of hundred. Now it's over 400. Probably in a couple of years, it's going to be 700 or 800. And so they do this gene panel, and this can identify many of the important single genes associated with epilepsy. There's also what we call targeted testing, and that's if you really think that this person has this specific gene change. So that's done if a specific genetic epilepsy is suspected, or if we already know that there's a genetic cause of epilepsy in a person, and then other family members may have targeted testing. That is done much less commonly because usually it costs as much to do a targeted test as to do the whole gene panel. And then what we call a chromosomal microarray. And what this does is it looks at your chromosomes, which are the structures that contain your DNA, and it looks to see if there's any imbalances. So sometimes people have a little bit of an extra piece, or sometimes people have a very, very small loss. And so that can be looked at to see if there are genes missing or extra genes that can cause epilepsy. And then probably the most complete one is something that we call a whole exome, or now they're starting to do a whole genome sequencing. And here it's a much more involved test. Typically what they do is they look at the person with epilepsy and if possible, their mother and father. And this involves looking at the entire DNA code to look for changes in genes associated with epilepsy. And here is where you can sometimes get into an issue by finding a gene that is unrelated for epilepsy because we're looking for all of these. So, you might find a breast cancer gene or something like that. So what are the tests? What kind of tests can you get back from the gene testing? Sometimes you get positive tests, and this tells you that you have this specific gene, and this specific gene is associated with epilepsy and is highly likely to be the cause of your epilepsy. And so that can give you important information on reproductive risks, how epilepsy is inherited, but also really important information on how you can treat this epilepsy the best. And then there's the negative test results. This is where we don't identify any gene cause. Now, it doesn't completely rule out the possibility of a gene diagnosis because there's really only so many genes we can test for, but that doesn't give you an answer. Where I think that the challenge comes is some people have this come back. It's uncertain. We found a change. We don't really know what to make of that change. We don't know if that change is responsible for your epilepsy or not. And it's what we call a variant of uncertain significance. And in many cases, the genetics doctors and the neurology doctors will look very carefully to see what type of epilepsy is that potentially associated with the gene change. But sometimes you end up not knowing. But importantly, we are learning about genetics all the time. And so many times, even if you look at these results, you relook at these results in a couple of years, the geneticist can now say, oh, well, no, now we know that that's a completely benign variant and we don't have to worry about it. Or now we know that this is highly associated with epilepsy. So if you've had this test done and you've had this result and it's been more than a couple of years, it's worthwhile relooking at that. Insurance coverage for genetic testing, just a few words there. So each insurance plan has its own rules covering genetic testing. The genetic testing can be quite expensive and so important to work through if this is going to be a testing charge to your insurance, that your insurance will cover that. Other lab studies that we do, so sometimes we'll often do basic blood work looking at sugar or salt levels, often in new onset seizures, but overall the risk or the chance of finding a cause there is quite low. People who have loss of developmental skills, so generally children, or other signs of what we call a metabolic disorder, which is how they break down their nutrients, can undergo further blood and urine tests looking for that. And then people who have what we think are autoimmune epilepsies, here we can actually do some blood testing or spinal fluid testing to look for those abnormal proteins, those abnormal antibodies. So to conclude, we know that epilepsy is common, right? 1 in 26, but we also know it can be mimicked by several other conditions. And so really important to get the diagnosis right. It is not just one disorder. There are many, many different causes of epilepsy, and the type of epilepsy you have and the underlying cause is really critical to understanding how to best treat your epilepsy, and also really important to provide accurate prognosis for how that epilepsy is likely to behave as far as responding to medicine or being outgrown. The EEG is our most common test, but it is not a perfect test, and it can be normal in people with epilepsy, and it can be abnormal in those without epilepsy. So again, you cannot make a diagnosis of epilepsy on an EEG alone. And many tests can be done to look for the underlying cause. And so really working with your healthcare provider to select the ones that are most relevant to you, I think is most important. Great, so thank you very much, and happy to take any questions.
Okay, we do have a couple of questions in here, and I do encourage everyone, we have some time for questions. So if you think of any as we go, please get them typed in so that we can get Dr. Wirrell's expertise while we have her here. The first question is, how do I know if it's epilepsy or just a seizure disorder?
Okay, so that's a good question. So those two terms are often used fairly interchangeably. A seizure is a much less specific term. So a seizure simply means that your brain had triggered some type of seizure, and that can be due to what we call something that is provoked, like a child with a high fever, or if I give myself a huge dose of insulin and my sugar drops super low, I'm going to have a seizure. Or somebody who has a very bad traumatic brain injury with blood on their brain, they can have a seizure. So seizures are really non-specific, and if you just use the term seizure, that really, we don't know if that is due to a provoked cause, like low blood sugar, high fever, or if it occurs in somebody who is predisposed to epilepsy. And so somebody who has recurrent seizures where they have not had a clear provoked cause most likely has epilepsy. Some people, you will use the term seizure disorder instead of epilepsy, but I think it's important to be as specific as we can. And so if you have recurrent seizures and there hasn't been a clear underlying cause for those, like high fever, like low blood sugar, that's probably epilepsy.
Okay. The next person has a couple of questions. What are you seeing regarding vaping of high-dose nicotine or high-potency THC in seizures? Yeah. And secondly, emotional trauma and or PTSD and changes to amygdala and insula leading to epilepsy.
Yeah. So, so vaping, I'd like to address that. So we have actually seen a number of patients. I personally have a number of patients who vape. And when they vape a lot, and some of them even when they vape less amounts, that has been a clear trigger for their seizures. So I really think that vaping for many adolescents, and remember, I see predominantly children and adolescents, but for many adolescents, I think vaping can be a significant trigger for seizures. And so that's really something to watch for. The second question is whether post-traumatic stress disorder can change the amygdala and cause seizures. Is that right?
Yes, I think that's what they're asking.
Okay. So I think
emotional trauma.
Yeah. So I think emotional trauma and seizures, there's actually a really interesting relationship with that. So many, I think if you have emotional trauma, there's two possibilities. You could certainly have emotional trauma and epilepsy. Or you can have emotional trauma that gives rise to what we call functional spells or functional seizures. So those are events that often can be mistaken for seizures, but are not epileptic seizures, right? And are treated in a different way. If we look at people who have emotional trauma, so when they did a big study in Iceland, And what they found was that having depression was actually a risk factor for developing epilepsy. So I do think there is something that probably goes along with having long-standing depression that maybe makes you at higher risk of epilepsy or leads to higher risk of epilepsy. And there's been some suggestion that also if you have uncontrolled depression with your epilepsy, people who end up going through epilepsy surgery may not do as well, may not have the same degree of seizure freedom following. So, you know, I don't think we understand exactly what causes that, but I think there's an interesting relationship there. And I think that just speaks to the importance of you know, being aware and managing those other comorbidities, right? If you have depression and epilepsy, you really want to be treating that depression as well as treating your seizures.
That's very interesting. Thank you. I just want to follow up on the vaping question. So when you talk about vaping being a seizure trigger for some people, can vaping cause epilepsy in someone who doesn't already have it?
That's a good question. I don't think we know that, but the kids that I've seen, I think, you know, everybody, so if we all have seizure triggers, right? You and I have seizure triggers. Most of us, our seizure triggers are, you know, high enough that we really have to, you know, we have to be sick and super overtired, and then we have to drop our blood sugar, and then we have to have a head injury, and then maybe we'll have a seizure if all of those things stack up. People with epilepsy have lower seizure thresholds, so they will have seizures with lesser amounts of triggers. And so I think in those situations, you know, vaping, which can activate brain activity, is enough to push that, to kind of hit that level for their trigger to take off and to generate a seizure. I don't know that there has been clear data to show that vaping per se causes epilepsy, but it certainly exacerbates seizures in people with epilepsy.
Okay, thank you. Very interesting. The next question, what is a T2 abnormality on MRI?
A T2 abnormality on MRI, it's so we do different sequences on MRI. They just some of them show the brain is more gray, some of them show the brain is more black, or the spinal fluid is more white. And T2 is just a type of picture that we take on the MRI. And oftentimes abnormalities in the brain show up looking bright on T2. And those can be a different abnormality. So sometimes it's fluid-filled cysts, sometimes it's what we call a focal cortical dysplasia, sometimes it's areas of scarring, sometimes it's little tumors, but many of the changes that we see on the MRI will look bright on T2.
Okay. Is status epilepticus a type of seizure?
So status epilepticus is a seizure emergency. It's not a type of seizure. So you can have different types of status epilepticus. So all what status epilepticus means is that your seizure has gone on long enough that it is unlikely to stop on its own, and that it is posing then a risk for ongoing brain injury to you. And so if you have, you can have different types of status epilepticus. So the most common one that we think of is convulsive status epilepticus, where the whole body is involved and you're shaking. And if that goes on longer than 5 minutes, it is unlikely to stop on its own. And so we say at that point, 5 minutes is impending status epilepticus. And that's when we start to really, you know, put medication to try and stop the seizures. You can also have what's called focal status epilepticus. And so people with focal status epilepticus, sometimes they just have shaking on one side of the body. Sometimes they can have just what we call a focal impaired awareness seizure. So they're just very confused. They may be sitting there and, you know, chewing and not responding to you, or mumbling, or things like that. If you have a seizure starting just from one focal area in the brain, the risk is probably lower that it's going to damage the brain, but it's not zero. And so typically in that situation, we would jump in at about 15 minutes. And then other people can have what's called absent status epilepticus. So it's an absent seizure, and you're just kind of in and out of this foggy state for prolonged periods of time. That's also status epilepticus. And typically we would jump in and start treating that maybe at 30 to 60 minutes because we know the risk of an absent status is much, much lower than a convulsive status. So status epilepticus is just saying the seizure is a prolonged seizure and unlikely to stop on its own. And potentially now at the time that if it goes on longer, it could potentially cause further injury to the brain.
Okay, thank you. When is it determined that your epilepsy is drug resistant? And what are treatment options for drug resistant epilepsy?
Yeah, that's a good question. So we define drug-resistant epilepsy as someone who has been through and tried 2 anti-seizure medications that are appropriate for the type of seizure they have. And those medications were tried at appropriate doses and yet have failed to stop that person's seizures, right? So that person has ongoing seizures despite trials of 2 anti-seizure medications. And in that situation, it really depends on, again, what is the underlying cause of the epilepsy? Is there an underlying epilepsy syndrome? So typically we think of further treatments in different groups. So there's always more medicines. Sometimes in certain types of epilepsies, we know that one medicine can be highly effective when other medicines have failed. And so sometimes if we know the cause, we can pick a certain medicine and say, that's the one we want to use. For many of our patients, we know that further medicines are unlikely to work based on their type of epilepsy. And so some of those patients can be really good candidates for epilepsy surgery. And the epilepsy surgery is where we try and identify where the seizure is coming from. And if we can safely resect that area or remove that area where the seizure is coming from and then leave that person without seizures. Other things that we can do for drug-resistant epilepsy. So sometimes we use a special diet called a ketogenic diet that can be effective for certain people with drug-resistant epilepsy. And then sometimes we'll use things like what we call neuromodulation, so vagus nerve stimulation and deep brain stimulation. I think the important thing is if you have drug-resistant epilepsy, you really want to be seen in an epilepsy center. So there's a comprehensive epilepsy program. And so I think general neurologists are certainly very capable of managing most epilepsies, but if your epilepsy is drug resistant, you want to find your way to a comprehensive epilepsy program so they can really evaluate what is the best options for you.
Great. Next question is, how is the CHD2 gene associated with DEEs diagnosed?
So the CHD2 is a gene that we see. It is one of those, 700 or 900 that I talked about that can be associated with epilepsy. And the CHD2 gene in and of itself, if you have what we call a pathogenic variant in that gene or a pathogenic change in that gene, that is enough to cause epilepsy. And so many of those children will develop a lot of myoclonus or other generalized seizures. And exactly how it causes that, I don't think we have a clear understanding, or how it causes some of the developmental concerns. But many of those children have, in addition to quite challenging epilepsy, some learning issues as well.
Okay. How common is extreme anxiety when taking Epidiolex?
So that Epidiolex usually does not cause the anxiety. In many people, it actually can temper the anxiety a little bit. So it would be unusual that somebody would develop extreme anxiety that would be due to the Epidiolex. Anxiety, however, is a really common symptom in people with epilepsy. And so we often will see people with epilepsy have challenges with anxiety and that's again very treatable. Sometimes we do see people who have unusual responses to certain medications. So, it could be a very rare issue for Epidiolex that happens very, very rarely in one person. But in most cases that I've seen, I don't think I've seen anybody with extreme anxiety due to Epidiolex.
Okay, great. This person wants to know your thoughts about CBD and gummies to help seizures that aren't controlled with meds.
Yeah, so I think looking at CBD, I must say I have some concern. So there are different types of CBD. So there's what we call pharmacologic grade CBD. And that's one that I feel a whole lot more comfortable with, because I think there have been very careful studies done on the pharmacologic grade CBD. And what that means is that it is tested. We know exactly what's in it. And importantly, we know exactly what's not in it. And we know how that, if it's a plant-based, we know how those plants are grown. We know that, that there's not a lot of pesticides or herbicides or things like that. So I think for the pharmaceutical grade CBD, I think that does have a real role in the management, particularly of the more challenging epilepsies. I think the non-pharmaceutical is where I get more anxious because we don't know what's in it. it's not carefully regulated, it's not carefully tested. You're kind of at the mercy of whoever is selling it to you, because you can go on the street and say this is what it is, and nobody is going to test that and say no, it's not. And so I think it's much more buyer beware, because you don't know what's in it. You don't know if there's a lot of THC, and I think THC is not a safe thing to use for people with epilepsy. You don't know if it's been grown with a lot of pesticides or herbicides, so you could be giving a lot more chemicals to your loved one with epilepsy. So I think you really do need to be cautious about that. And I think whereas I would be quite comfortable using a pharmaceutical grade CBD in many persons with epilepsy, I would be much less comfortable using a non-pharmaceutical grade one.
Okay. I had a right temporal lobectomy for complex partial seizures 20 years ago, and 10 years ago, an MRI showed a meningioma on the left side of the brain. What causes a meningioma? And I don't know if I'm pronouncing that right.
Yeah. So meningiomas most often are occurring for reasons that we don't really understand. There are some potential genetic conditions that can make you more at risk for meningioma. And then the other thing that can make you more at risk for meningioma is if you've had prior brain irradiation for any reason. So, if you had a prior cancer or something like that, and you were treated with radiation, particularly, even in childhood, that can cause, put you at risk for having meningiomas down the road. But that, if you just had epilepsy, you had no brain radiation, you had a right temporal lobectomy, I think probably it's just bad luck that there's now a meningioma on the other side. And I'm really sorry to hear that.
Okay, I think we have time maybe for one more. My daughter has a rare syndrome diagnosed at age 13. She has intractable epilepsy with different types of onset. Would you recommend doing genetic testing to find out possible potential better treatments?
Yeah, I think in that situation, so I think the question is, what syndrome is it? And do we already know a cause, right? So sometimes the structural, the imaging will give us a clear cause, but I think if we don't know a clear cause, boy, if you have drug-resistant epilepsy that came on in childhood, absolutely, I would recommend talking to somebody about gene testing. Okay.
And there's only one more, so I'm going to go ahead and get that. Oh no, there are several more. Never mind. We're not going to be able to get to all of these. I had one and then two more popped up. So I think we're going to probably have to cut it off there. I don't know if you would like, if your question's not been answered, you can certainly, I can see if I can find answers for you and get back to you individually. I have all your emails, so I apologize, but that tends to happen. We just don't ever have enough time for all the good questions.
Great to see the interest, though.
Yes, it's great to see the interest. I'm really glad about that. So now I just gotta get the slides moving again. There we go. I just want to remind everyone that the Epilepsy Foundation's mission is that we lead the fight to overcome the challenges of living with epilepsy, to accelerate therapies to stop seizures, find cures, and save lives. That's really what we are all about with the Epilepsy Foundation. I just want to put a plug in for our client services. We do, as I mentioned earlier, offer free one-on-one support with customized tools and resources on a variety of epilepsy-related subjects. So if you have questions about anything related to epilepsy, please reach out to us. There is a form on our website that you can fill out, and we will be happy to try to address your specific needs as much as possible, and try to find you the information, the resources, and possibly referrals if you need them. So the address is there, efmn.org/information-services. I want to thank our sponsor again, Mayo Clinic, for supporting this webinar tonight. I want to thank all of you for attending, and I especially want to thank Nikki Baker, who's there in the background doing all the tech stuff, and I want to thank especially Dr. Wirrell. This has been very interesting. We realize how busy you are. We realize how respected you are, and we really are thrilled to have someone with your knowledge and expertise be here to help with this. This has been this is a topic we haven't dealt with before, and I think it's been a really valuable evening. So thank you again, Dr. Wirrell.
Thank you, and thanks for everyone for joining tonight.
And with that, we will say good night. Oh, no, we won't, because I'm going to do one more thing. I forgot I had one more slide. We will have another Wellness Wednesday webinar. We're taking the rest of the summer off, but we'll be back on September 20th with Dr. Douglas Smith from the Minnesota Epilepsy Group, and we'll be doing an even deeper dive into genetics in epilepsy. And with that, I will say good night and thank you again, Dr. Wirrell. Thank you all for attending.